The last video covered the clinical manifestations of community-acquired pneumonia. This sketch note summarizes the key facts you need to know about the clinical presentation of pneumonia. Remember, when obtaining a history, focus on four things: the epidemiology. In this case, the elderly have a 1 in 100 chance of developing pneumonia, and it usually develops in the winter months. Past medical history, such as stroke and other conditions that may compromise the upper airway. Pace of illness, was the onset acute, subacute, or chronic? And finally, what were the key symptoms and signs? For pneumonia, you want to focus on cough, chest pain, and shortness of breath. In this video, we'll be focusing on how to diagnose community-acquired pneumonia and how to make an educated guess based on the clinical presentation of the most likely pathogen causing the patient's pneumonia. The most common cause of community-acquired pneumonia is Streptococcus pneumoniae, representing 40% of cases. This infection occurs more commonly in the elderly and those with chronic diseases, as well as intravenous drug abusers. The pace of the illness is acute, and patients are often severely ill. Unique clinical characteristics include patients may complain of a rigor, shaking chill, indicating bacteremia. They may produce rusty, purulent sputum reflecting red blood cells and neutrophils in the alveoli, and may experience pleuritic chest pain when the infection reaches the periphery of the lung, and can experience shortness of breath, a worrisome sign. Chest X-ray usually shows a lobar pattern and less commonly bronchopneumonia. Patients with peripheral infiltrates can develop an empyema, a collection of purulent fluid in the pleural space that usually requires drainage. The second major cause is atypical pneumonia, which is caused by first Mycoplasma pneumoniae and Chlamydophila pneumoniae, usually found in young patients aged 18 to 40 years of age. The pace of illness is usually subacute onset, and there is scant sputum. Disease is often mild, and these pathogens are the leading cause of walking pneumonia. The second group is Legionella, a more severe form of atypical pneumonia, and I will cover this separately. The third leading etiology in this group is viruses, in particular influenza, less commonly adenovirus, parainfluenza, and respiratory syncytial virus. Elderly are at high risk for influenza. The pace of illness is acute to subacute, there is scant sputum, and patients can be severely ill, particularly the elderly. Chest X-ray demonstrates a fine interstitial pattern. 3. Haemophilus influenzae, a more common in smokers. It's subacute in onset. Patients are usually only moderately ill, and chest X-ray demonstrates a bronchopneumonia. 4. Legionella pneumophila. The epidemiology of this disease is unique. It is often associated with contaminated cooling towers and shower heads, as well as areas where excavation is being performed. This infection is more common in the elderly, smokers, and immunocompromised hosts. This infection is acute in onset and is accompanied by scant sputum, and there may be GI complaints and hyponatremia, low serum sodium. Patients often are severely ill. The chest X-ray can show a lobar or an interstitial pattern. 5. Staph aureus. This is a rare cause of community-acquired pneumonia and usually follows influenza. This pathogen is usually associated with nosocomial pneumonia and also seen in patients with cystic fibrosis. It can also be seen in IV drug abusers. The onset of illness is acute and patients are often severely ill. Purulent sputum is noted, and pleuritic chest pain is frequent, and there is marked shortness of breath. Chest X-ray demonstrates a bronchopneumonia, may also show abscesses, and spontaneous pneumothorax can occur, requiring chest tube placement. The sixth leading cause of community-acquired pneumonia is gram-negative rods, Klebsiella, Pseudomonas, Burkholderia cepacia in patients with cystic fibrosis. The epidemiology is often hospital-acquired or nosocomial, also found in the elderly living in nursing homes. Other predisposing factors include cystic fibrosis, and in addition to Burkholderia and Staph aureus, these patients are commonly infected with Pseudomonas. HIV patients also have a higher incidence of gram-negative pneumonia, as do alcoholics, who have a higher risk for Klebsiella pneumoniae. These infections come on acutely and patients are severely ill. They usually have purulent sputum production and chest x-ray shows bronchopneumonia. And finally, aspiration pneumonia, usually due to mouth flora, non-typable streptococci and anaerobes. Patients with poor dental hygiene, alcoholics, and those taking sedatives, and patients with strokes are predisposed to aspiration pneumonia. Onset of illness is acute and is usually accompanied by a productive, foul-smelling, purulent sputum and also pleuritic chest pain. Chest x-ray shows bronchopneumonia as well as lung abscesses, and empyema may be developed if treatment is delayed. If considering pneumonia, in your differential, what tests should you always perform immediately or stat? If pneumonia is high on your differential diagnosis, a chest x-ray should always be performed. There are 5 typical patterns of chest x-ray. 1, a lobar pattern. 2, bronchopneumonia. 3, interstitial pattern. 4, lung abscesses. And 5, nodular lesions, usually associated with chronic infections. It should be emphasized that this is only a rough guide and there is overlap between the different patterns. Here is a classic lobar pneumonia. Remember, strep pneumoniae has no proteases and therefore is confined by the fissures. This pattern is only seen in bacterial pneumonia. In addition to strep pneumoniae, this pattern can be seen in Klebsiella and Legionella. This is a classic bronchopneumonia pattern, and this form of infection is seen in Staph aureus, Haemophilus influenza, gram-negative pneumonias, and less commonly in strep pneumoniae. This is a classic interstitial pattern, and this pattern is seen in Mycoplasma, Chlamydophila pneumonia, and Chlamydophila psittaci, Legionella, and viral pneumonia, influenza, adenovirus, RSV, and CMV. This x-ray shows a large circular abscess on the right side with fluid in the base of the abscess. Lung abscesses are most commonly seen in aspiration pneumonia, but also can be seen in Staph aureus pneumonia. And finally, a chest CT showing a lung nodule. These are most commonly associated with the fungal infections like Cryptococcus, histoplasmosis, and coccidiomycosis, or mycobacteria. They also are caused by lung adenocarcinoma. Let's stop here and cover the additional diagnostic tests along with treatment in our final video. To summarize this section of my talk, we have reviewed the unique clinical characteristics of the most common forms of community-acquired pneumonia, and I have included all etiologies listed in First Aid for USMLE Step 1 to assure you have the proper information for your board exam. There are 7 major categories of pneumonia: strep pneumoniae, atypical pneumonia, Haemophilus influenzae, Legionella, Staph aureus, gram-negatives, and aspiration pneumonia. And there are 5 chest x-ray patterns: lobar, bronchopneumonia, interstitial, abscess, and nodule. In the next video, we will cover how to use gram stain, when to draw blood cultures, and other diagnostic tests helpful for making the diagnosis, and review antibiotic treatment and the use of vaccines to prevent this serious infection. Thank you.